This is the topic assigned to me, current minimally invasive surgery practice. And the minimally invasive approach for hepatocellular carcinoma had a slower diffusion compared to other surgical fields, and mainly due to inherent peculiarities regarding the risks of uncontrollable bleeding, oncological inadequacy, and the need for both laparoscopic and liver major skills. Liver resection skills. Also, because of cirrhosis, the technical difficulty comes along with the challenge in the control of hemorrhage and the transection planes, plus sometimes anatomical factors such as obesity and also the change in the configuration of the cirrhotic liver, and including the variants of the complex hepatic anatomy makes part of the technical challenges. Apart from that, there is also a very investment-heavy part, which is the technology dependence of laparoscopic liver resection, where you need even preoperatively very good scanning and simulation for a very good surgical planning by 3D imaging. And during surgery, you need high definition visual systems, energy devices, and staplers, and of course, laparoscopic ultrasound, which makes a big impact on the way we do laparoscopic anatomical liver resection. And likewise, the other important challenge also is to be able to coordinate everything within the operating room with everyone as a team approach. So these are these are the overall general challenges that we face. Now, we need to go back to the different stages in terms of the evolution of the indication for HCC. So I think everyone is familiar with the Louisville consensus statement in 2008, where one portion was dedicated to hepatocellular carcinoma and its use of minimally invasive liver surgery. And it has shown that minimally invasive liver resection plays a role and can be safe. And thus, this was very important landmark because during this time, safe dissemination of laparoscopic liver surgery was the highlight of this consensus statement. Next, it was followed by Morioka consensus in 2014 in Japan, where the different factors affecting the outcome of laparoscopic liver resection and also the indications were discussed. And during this time, there was a jury composed of some expert HPB surgeons who are not practicing laparoscopic liver surgery. So in this particular consensus conference, nothing specific about hepatocellular carcinoma was truly discussed, although there was an important portion dedicated to the recommendation on difficulty scoring, which I would talk about in a while. The next one would be on the Southampton consensus guidelines in 2018, where indications, patient selection, procedure types, technique, and implementations were discussed. And this guideline provides a graduated methodology for experienced liver surgeons to incorporate laparoscopy into the practice. From a technical aspect, standard principles used in open liver surgery should also be used to reduce morbidity and mortality. And this applies to laparoscopic liver surgery as well. So if we enumerate and tabulate all these three, we will see the difference where difficulty scoring was highlighted in the Morioka conference, and this was later on established in the HE.RC.O.LE.S conference in 2019. And common to all was training. Training was highlighted such that this becomes an important part of the dissemination of minimally invasive liver surgery. And of course, caution on the laparoscopic donor hepatectomy was also mentioned in this particular conference. In general, the Southampton guidelines mentioned low-risk patients and less technically complex procedures are advocated during the early implementation of laparoscopy, and also stresses the importance of having 2 experienced surgeons in the implementation of any minimally invasive liver surgery. What is important here is that it mentions decreased blood loss, transfusion rate, postoperative ascites, and liver failure plus hospital stay in patients with HCC and even in patients with Child-Pugh-B score. But patients with Child-Pugh-B score should be taken with caution as an indication. So the 3 guidelines were in general for the procedure itself, procedure of minimally invasive laparoscopy, laparoscopic liver surgery. What I'd like to show here is that before these guidelines, in 2005, Professor Kaneko from Japan highlighted their series of minimally invasive liver surgery for benign and HCC, because in Asia, majority of the cases are hepatocellular carcinoma. And they found that even Child-Pugh-B patients can also can actually be performed in these cases with safety and with caution. And at this time, it was recommended that tumor size should be limited to less than 4 centimeters and less than 6 centimeters if pedunculated. And in terms of location, they should be in the lower or the peripheral segments. While the types of laparoscopic liver resections were partial hepatectomy and left lateral sectionectomy, and also segment 6. Moving on to 2017, in Hong Kong, we have there was an Asia-Pacific consensus statement for HCC, in particular, only for HCC. And it was a little bit more conservative, where only Child-Pugh-A was recommended as an indication, and tumors less than 5 plus anatomic resection is the type of laparoscopic liver resection for HCC versus non-anatomic liver resection. It was also at this time where centralization or centers of excellence was mentioned. So this was in 2018, which showed that in HCC, the underlying liver cirrhosis makes laparoscopic liver resection difficult because of the presence of portal hypertension and high bleeding tendency, and thus safe performance calls for ample experience. And the impact of cirrhosis makes bleeding a primary concern in the setting of cirrhosis, which is common in up to 80% of HCC. Movement restriction in lap makes bleeding control a major challenge as well, and often the cause of conversion. Truan reported uncontrolled bleeding causing 57% of conversion, while Sandro reported 1/3 convention, also due to bleeding. So if we look at the recommendation, there were, these are the following recommendations. Minor lap liver resection for early stage in segments 2 to 6, and also minor lap liver resection in segments 1, 4A, 7, and 8 should be performed only in centers of excellence, and lap major hepatectomy should also be performed only in centers of excellence. For patient selection, there is no difference with open hepatectomy, and lap is better tolerated in patients with marginal function. In terms of tumor size, it is best to keep within 5 centimeters in favorable locations. And if it's more than 5 centimeters, it should be done in centers of excellence, and more than 10 centimeters should be done with a lot of caution. Now, laparoscopic anatomical liver resection is highly recommended, but for superficial and peripheral HCC, wedge resection can be done for those that are less than 2 centimeters. So centers of excellence were defined in this guideline as that with a dedicated multidisciplinary team, where the center performs at least 30 laparoscopic liver resections a year, and surgeons must have performed at least 100 lap livers on their own over a lifetime in at least 20 cases per year. So moving on to the other recommendations, it was also compared between RFA and showed that recurrence rate is lower in lap for small HCCs, and it minimizes the risk of intrahepatic recurrence compared with RFA. Lap liver resection was also favored in peripheral segments 2 to 6. In terms of portal vein invasion, there was lack of evidence, and thus this was not recommended unless the portal vein thrombus is located on the left lateral aspect where a safe left lateral sectionectomy can be performed. And difficulty scoring system is useful. High to intermediate difficulty scoring scores should be left to centers of excellence, and there should be gradual improvement of skills according to the difficulty level, which is the same as what the Morioka and the Southampton guidelines have shown. In terms of the added tools, such as fluorescence-guided surgery, these may provide extra value and enhance the performance of the surgeon. 3D imaging would definitely enhance surgeon's performance, and whether robotic or lap is better, there was actually no significant difference found, but there was definitely a shorter learning curve in robotic surgery. Now, when we talk about a hepatocellular carcinoma, cirrhosis will definitely come into the picture. And so this is one of the systemic reviews and meta-analysis that shows the difference between open hepatectomy and laparoscopic hepatectomy in China, in a single center. It showed, in 17 studies in 2004 patients. 13 studies have shown that laparoscopic hepatectomy has less blood loss, less transfusion rate, less morbidity, lower mortality, of course, shorter length of stay, and favorable 1, 3, 5 years overall survival, and favorable 1-year disease-free survival, although there was no significance for 3 and 5 years disease-free survival between open and lap. So with this, it shows that lap hepatectomy is advantageous for cirrhotic patients. And for patients with child B cirrhosis, another multi-center propensity score match study showed in using data from 17 centers, where 78% were child B7, 43% were child B8, and 40% were B9. 100 lap versus 100 open cases were matched, and these were the following results. So the limitation, six patients were converted to open in this case, and the limitations were that anatomical versus non-anatomical resections were not matched in the present study due to the heterogeneity in practice among surgeons and centers. So patients without preoperative portal hypertension and child PU7 cirrhosis actually benefit the most based on this study. Here I have outlined and tabulated the differences, and as mentioned, B7 child PU patients would benefit more from lap liver surgery. Although there was not much difference in terms of mortality. In open surgery, blood loss again has shown much more, and a little bit more in the general morbidity, but major complications as well. And again, ascites was shown to be much lower and lesser median hospital stay. So in general, the findings have been the same with most of the studies. Same with this. In this study, I already mentioned that child UP7 is more beneficial. Currently, the evolution has gone through various extreme cases, such as large HCC, those of more than 10 centimeters. We have a fair bit of reviews and cases that have been reported. But for biliary tumor thrombus and portal vein thrombus and even IVC thrombus, these are relatively more extremely challenging and relatively less reported in the literature. However, in the recent WCES in Korea, Dr. Guo Xin from Taiwan has reported and showed his cases with IVC thrombus that were done laparoscopically, removing the thrombus from the inferior vena cava during the hepatectomy. So this should be left to very high volume centers and very expert centers where because the outcomes have not yet been verified. In general, it cannot be widely disseminated. So laparoscopic liver resection for large HCC has been shown to be possible. And this was a study shown by Sandri, and this is from Italy, showing that there was not much difference in terms of the outcomes. Overall survival also showed no difference. So short and long-term survival were relatively the same. So the Taiwan group has shown the same, has shown a different outcome. And so they were questioning and argued whether there was really a benefit for large HCC, since their outcomes showed that they have a higher stage 3 disease, more blood loss, longer operating time, and higher complication rate. On the other hand, in Singapore, a single surgeon study showed that size doesn't matter, and there was no major difference between less than 10 and more than 10 centimeters tumor, although there was only 15 cases of those with more than 10 centimeters. My personal data has shown that this is possible, and 41 patients have undergone laparoscopic liver resection in more than 6 centimeters of tumors with a range of 6 to 14 centimeters, difficulty score of 9.2, but we do have a fair bit of blood loss ranging from 250 to 1.2 ml OR time at 420 minutes mean, and a complication rate of 9% in lap liver, which is definitely much less than those with less than 6 centimeters. Hospital stay is also a little longer, but in general, there was no mortality nor morbidity. No major morbidity. Most of the morbidities were wound SSI or pneumonia. This is to highlight that cirrhotic livers in HCC, when they are large, can also be downsized, and subsequently a laparoscopic liver resection can be done. In the interest of time, I think I will skip this video. So most of the cases, most of the evidence has shown were not randomized controlled trials. Currently, there's a couple of RCTs done to show. The one that was recently published showed a difference between lap anatomic versus lap non-anatomic for liver for HCC. Plus, there are 2 others that are ongoing. So for the recent publication, the lap anatomic versus non-anatomic hepatectomy has shown that the indications were those of Child-Pugh A and B with ICG retention less than 10%, RLV should be more than 40%, and single lesion of less than 10 centimeters with no vascular invasion. So these are their inclusion criteria. What was significant was total operative time, where lap anatomic hepatectomy was longer, took a longer time than the non-anatomic hepatectomy. But overall survival remains the same, and the disease-free survival was better in anatomic liver resection for the long-term outcomes. For the short-term outcomes, the only difference was a surgical margin, where non-anatomic hepatectomy showed a little, some positive margin. Overall recurrences was also higher in non-anatomic hepatic resection. Now, these are the two ongoing trials, randomized controlled trials with no results yet. They are still ongoing. And I also want to highlight the importance of minimally invasive repeat liver resection for HCC. 18 studies were included in this analysis, and almost all were retrospective except one prospective, but only an abstract. A majority were done lab versus robotic. And it was shown that in the Japanese group, they have the highest number of patients with repeat liver resections, and this was proven to be beneficial and feasible and beneficial and safe with an median OR time of 398 minutes and EBL up to 200 ml. So mostly were Child-Pugh A. So this brings us to this important study also that showed that laparoscopic approach to iterative surgical treatment for HCC has demonstrated protective benefits, and it can serve as a bridge to liver transplantation because most patients develop recurrences. And so having a laparoscopic liver resection for these patients at the get-go would definitely allow repeat liver resections and even liver transplantation. So just to end the talk, I'd like to say that arriving at today's real-world clinical practice in the management of HCC has started in 1993 with feasibility that was proven, and then followed by the expansion. And this triggered the exploration of minimally invasive liver resection in all types of diseases, although there was an increase in resections as benign, for benign lesions as well as part of the learning curve. But in Asia, the indication remained to be HCC as majority. And reality later sets in with the audits, mortality and morbidity, which were examined. And expectation, sadly, has plunged because we needed to achieve the learning curve. And in fact, 2 mortalities triggered a national assessment in Japan 15 years after its expiration. Thus, this brings us to the next stage where we need to establish consensus guidelines and difficulty scoring. We need to create societies for oversight and governance, and also important for us to develop registries to monitor our outcomes. And the Italian group has done a very good liver registry on this as well. So these would all bring us to standardized techniques, improve our training and practices, and of course, to improve the quality of laparoscopic liver surgery. So in conclusion, MILS can be feasible and safe, and selection of patients is key, especially for HCC, and complex cases should be performed in centers of excellence to avoid morbidity and mortality. Training is necessary, repeat resections are feasible and safe, and MILR acts as a bridge to liver transplantation. Thank you very much for attending.